दो सीट है ना, 2 सीट है ना, 16 का। Morning, everyone. This is the first certification program, so I would like to request sir to give a start welcome speech to the participants.
Welcome to our Eternal Hospital by the physicians, respected physicians, and the whole staff here with our TAVI team and TAVI program. We had done a lot of other workshops, and this is the first of its kind for the TAVI, and we have few cases scheduled. Goal will be to just go through various steps and be part of it. We'll have some complex cases also. So anytime when I do my preceptorship back in Mount Sinai also, so not only they just watch and in the structural cases, but also complex coronaries. We had cases also, so you'll be welcome to be there. And I don't know exact format will be in the cath lab or will be shown here, whichever way will be, but will make your day useful and fruitful. So once again, welcome, and I'll start now Dr. Amit Chaurasia to take us through with the program. Come in.
We have two TAVI cases lined up today. The plan is four of you can scrub inside the cath lab. Four of you can be over here if you want to see from here or in the console. We also have lined up some Rota Pro cases. So if you want to be a part of that, you can be part of that also. Sir is doing some Rota Pro cases. So let's go through the first case. She's a 68 years old female, known case of hypertension for 7 years, had colorectal cancer for which she has undergone surgery and chemoradiotherapy. Now she has a colostomy bag which needs to be changed every Monday to Monday. And she underwent spine surgery in 2019. She has presented to us with functional class 3 dyspnea over the past 6 months, and echo showed good LV function, no regional wall abnormality, aortic valve area of 0.37, mean gradient of 67, and maximum velocity of 469. We did a CT scan for this patient, and the perimeter derived diameter was 18.6, very small annulus this patient has. The minimum diameter is 17.5. The valve looks mainly fibrotic rather than calcified in this case. The alveoli dimension is perimeter derived is 19.4. So we plan to go with a 23 millimeter Evolute Pro valve in this. This valve will give maximum effective orifice area as well as minimum gradient in a smaller annulus. So smaller annulus, these valves, supraannular valves are preferred. If you see the amount of calcium, it's only minimal calcium on the valve. So we can think of implanting the valve direct even, not even without a pre-dilatation in this case. The height of the coronary, left coronary is 15 and the right coronary is 16.9. So we are much above, as we discussed yesterday. We require 10 millimeter minimum height of coronary. If we see the amount of calciums, the amount of calcium over here is quite a good amount of calcium, but I don't think we need any kind of cerebral protection device in this case. If you see the implanters angle, the two implanters angle given are LAO caudal, LAO 1 and caudal 5, and RAO caudal 21, 21 RAO and caudal 26 if we go for a what is called as cuspal overlap technique. The femorals are a slight challenge in this case. However, if you see the bifurcation is low, so you can take puncture anywhere on the femoral head. The minimum diameter is somewhere around here, but still the diameter is more than 5. We are going to use a 16 French sheath in this case because it's a Evolute Pro. It will require at least 5.2 or 5.4, but we are well above that. Should not be a problem. Here, there seems to be some amount of ulceration over there, but we also feel that could be an artifact because of the low feeling of the contrast. You can see spinal 3 screws over there post spinal surgery patient. So the plan in this case is we take the left femoral puncture, we cross over, inject, take the femoral puncture on the femoral head, put the sheath, go with the L1 catheter, cross, implant the valve. If required, we post dilate. If not required, we won't post dilate in this case. If sir has any other.
No, I think this one we can just go with a direct inline, so it will be a smaller sheet.
Yes, sir.
It will remain like 14. No need to go with a sheath. We just puncture and knowing that we are not thinking to do a BA after.
नहीं इसको खोलना है. I don't use I always use a Mac. Second case, the second case is Adopt में क्यों खोल रहे हो? PDF ये Adopt PDF ही तो नहीं है। अच्छा sorry. एक मिनट. The second case, she is a 76 years old female, that hypertensive for 10 years, had a old CVA but no residual paralysis at present. Came to us with progressive dyspnea. Over the past 2 months, she also has started having angina. Echocardiography showed no RWMA, good LV function, aortic valve area of 0.35, high gradient, 81 mean gradient, a maximum velocity of 572. If you see this case, it has a heavy calcification on the annulus itself. The mean area perimeter derived diameter is 21.7. So we are going to go with the 26 millimeter valve. The minimum dimension is 19.4 in this. So if we'll pre-dilate this valve with the 18 millimeter balloon. You can see a lot of calcium. It's a functional, something like a functional bicuspid valve. When we pre-dilate, this raphe will give up. So it is going to behave just like a tricuspid after we pre-dilate this valve. You can see the calcium extends into the LVOT as well. And due to which we felt like this patient, if we put in a Evolute R, might have some amount of leak. So we decided to go with Evolute Pro in this case also. Heavy calcification on the leaflet as well. You can see the amount of calcium going into the LVOT, huge calcium also on the right side. The coronaries are very, very good height. In this case, we have not done the coronary injection until now, so we'll do a coronary injection before the TAVI right on the table. The right coronary height is 18.4, so no problem for the coronaries. This is just to show the chunk of calcium on the both side going into the LVOT. Huge calcified valve. For this case, the coplanar view is again LAO caudal 15 or 14. If we go by cuspal overlap, then it is RAO 14 and 35. Heavy calcification, so we plan to pre-dilate the valve with a 18 millimeter balloon and implant a 26 millimeter Evolute Pro in this case. So femorals are good both the sides. So we are going to take the, since in both the sides, you can see the height of the bifurcation is the same. We are going to take the right side as the therapeutic side, left side as the diagnostic side. So we come from the left side, inject again, see the puncture site, puncture, put the proglides, put the sheath, take the AL1 catheter, cross it, pre-dilate it with a 18 millimeter balloon, implant the valve. After we implant the valve, if still gradient is there, then we post dilate, otherwise we just close and become. Uh,
This one, what is the minimum?
So the minimum is 19, so 1 millimeter. Average is 21. So
18 will be, because then very likely with this calcium, your bunch of calcium is expanding. Both post dilatation, so you want to avoid that. Let's just do a pre-dilatation, use a 20 millimeter balloon. So you can use a 20 millimeter, and so that will avoid post dilatation. A lot of data now that if you avoid post dilatation, post BAV, less CVA. Sometimes we have to do it. It's still PVL left. There, then post dilate, otherwise pre-dilatation. And with the sapien, usually not necessary. Evolute, definitely.
So these are the TAVI cases lined up today. We start in some time. These cases are also going YouTube live. So all the discussions, any point, any place you want to ask questions, you can always ask questions. And feel free to. We
Will make you full TAVI Pro.
I completed my DL in 2017. About 4.5 years after my DL activity. Recently, I have
watch. So they'll have trouble 5-6% per year.
जो लेंगे लेंगे लेंगे
Why ECG is still wavy? We need to put our leads a little better.
Okay, I think
ECG सही नहीं है भाई. Somebody put the ECG a little better.
ECG ठीक
I
करो.
know. Yeah. Let's get the anesthesia thing two-pronged. Remember everywhere, so maybe. So Amit, they are recording, so keep saying what you are doing also, so
Yes,
everybody has.
now, as we start, we can
Nice.
after this we'll after the ECG they correct everything in place, then we can. No,
Angiography करनी है.
we'll have to do an angio.
Yeah. Never had any cath.
स्केल बढ़ा दो.
The speaker has to be on.
Uh,
Recording over.
माइक समीम सर के लगा हुआ है.
अमित सर भी
अमित सर के नहीं है, समीम सर ने लगा, हाथ दो के लगा हुआ.
चालू करो तो.
ECG.
बोलेंगे ना तब
नहीं,
आवाज आएगी.
वो तो चल ही रहा है ना. वो तो ECG है ही नॉर्मल.
Okay, so let's start. ठीक है?
Yes.
Yeah.
Hemant settled aside. Very crowded space today. Yeah. Yeah.
That's so. Good morning, everyone. Welcome to the live transmission of TAVI case, a small annulus case from Eternal Heart Care Center. This program is one of its kind, and we started as a workshop. Yesterday, we had a basic of TAVI, all with our participants who have come from different part of India. So now we are going to go case live. Before that, I would like to introduce everyone in the team. First of all, let me introduce Dr. Samim Sharma. I think he doesn't require any introduction. And then I have...
Welcome everyone, welcome.
Then I have Dr. Sanjeev Sharma with me. I have Dr. Navneet Mehta as our anesthetist. Dr. Hemant Chaturbedi as our echocardiographer will be showing us our echocardiography things. And we have a lot of technicians out of here, fellows, a lot of people from all over India who will be seeing these cases. And this case will be going live as well. So a small welcome address by sir.
Yeah. No, but this is a good, we welcome from ESCC Cardiac Cath Lab with our staff, ready to show two cases of TAVI today. And we start right from the beginning, and Dr. Amit Chaurasia will show step by step performance of the TAVI case, including the vascular access, how to obtain the right. The whole case in the TAVI at present is the vascular access, that you have to have appropriate, the right one. Any complication occurs, it's usually because of vascular. So vascular is very, very important.
So right now I have taken the left femoral artery, left femoral vein puncture. The left femoral artery, I have put a 7 French catheter over there. The advantage is that I can put hemodynamic monitoring. That is, I can get a continuous pressure monitoring from that. And you can see, even if I put a 6 French catheter, I will get my pressure monitoring over there. So what I'm going to do is I'm going to take a Lima catheter or a JR catheter, any of them, and sorry. So let me just tell you about the case. This lady is a 68 years old lady who had colorectal cancer and had undergone surgery for that. Then she underwent radio chemotherapy. In 2019, she had undergone spine surgery, presented to us in class 3 dyspnea, which had deteriorated over the past 6 months. Echo showed severely high gradient. I suppose if Hemant has done something, he can show up here. So the gradient was really high, and we had done CT for this patient. So someone showing the slides from outside, I think. Okay. So aortic valve area is around 0.38 centimeter square in this patient. We did a CT analysis, and the perimeter derived diameter was 18.6 in this case. So we have decided to go with the Evolute Pro 23 millimeter valve in this case. The femoral artery are just touch and go in some places on the right side. So what we are going to do in this case, the plan is, since the valve is not so much calcified, we'll be doing a direct implantation of the valve in this case. So let me start by saying we have taken a left femoral artery puncture, put in a 7 French sheath, a left femoral vein puncture, put in a 6 French sheath. Now what I'm doing is I'm taking a Lima catheter, a GR catheter, going to show each step to you. So I cross up there, I go with the catheter.
Patient has some spinal surgery also. A lot of screws will come in the way.
Okay, can you pass the wire? Yeah, let the wire go down. Okay, that's enough.
This is the light feed going on, correct?
So now what I'm going to do is I'm going to inject some contrast and see where the femoral head is, where the bifurcation is, and where I'm going to take my puncture. So I just focus on the femoral head and take an injection over there. So now you can see the bifurcation is way down. I can take my puncture right on the femoral head. So now what I'm going to do is I'm going to put back the thermo wire, and this will act as a guide where I'm supposed to go. Can you show me up, please? So now I have my wire over there, which will act as a guide. And can you come out, please? Just come out. I have not given any local until now. So I'm going to infiltrate.
Table down.
Table out. Just on the sides of the wire.
Give liberal
Very
lidocaine, 20-30 cc, because you're going to put a long sheath, big sheath. Need to be well anesthetized. Because anytime the patient, by the time you're done with the procedure, if it takes more than 1 or 2 hours, they really feel quite a bit.
Now this puncture is going to be guided, fluoro guided, because we have to hit exactly the right place while we do the puncture. So can you just Yeah.
Good. Not completely true, I think. It's a relatively small artery, about 5.5. You need at least 5, which is what it is, just about. Understood.
So you can see the puncture is in the right place. Now I'll pull out this because I'm going to put a pro glide. The pro glide should not catch our wire over there. That's necessary. Now what I'm going to do is I'm going to use blade to just give nick on the either side of the wire. Can you come out, please?
Come down.
Table out. Table out. Artery forceps. Yeah, till the artery. So now what I'm going to do is this is what I usually do to make a good space around just to dissect the subcutaneous tissue well. I put in a dilator and then go down and thus rotate it. So can I have the pro glides? So you can put 2 pro glide or you can do 1 pro glide with the 1 angioceal as well. So we are going to do 1 pro glide and 1 angioceal over here.
Yeah, in the past we were using 2 pro glides, but I think more and more people have gone now. Use a 1 pro glide and 1 angioceal.
So after the pro glide goes in, we just slowly push in the pro glide, pull out the wire and push in until you get blood coming out of there. Once you see that, you open the first step, come back, see the blood stopping up there, and then you actually put the suture line. Bring it out, cut it over there, close it again, and then you come out. You will get 2 sutures over here, which we pull out. Now, there's 2 dot lines over there from which the wire has to go back again.
In a little lighter. Good.
So you can see the wire going back. Usually I reconfirm it on the fluoro, and I see that the wire is in right place. So I just pull back till I get the wire, and then we put in a 8 French stitch now.
And if you need to put a second pro glide, you'll do it now.
Yeah.
So we are avoiding second pro glide and just 1 pro glide and 1 angioceal. Simpler, easier. Yeah.
So now you can actually, after obtaining a pro glide, you can give your heparin if you want. We give heparin at the rate of 100 units per kg body weight.
Okay, how much heparin now? Okay. And say patient is under conscious sedation, no intubation.
No
You can
intubation.
hear patient snoring a little bit. We want that.
So, diagnostic catheter, we have not done the coronary angiogram of this patient, so we are going to do it right now. But I have seen the CT and reconstructed the coronaries. There seems to be some minor plaque in the OM, otherwise everything looks fine in this patient.
Usually on CT, if we have any doubt, then we do a pre-angio and try to sort it out if it is a very complex case. Otherwise, what we do on the same setting, we do a PTCA as well as TAVI.
Good.
So you don't need many injections in this case. We just do one caudal and one cranial injection.
Yep.
Usually we put in a ariocaudal or epicaudal. This looks fine.
You don't even need a second one. That's fine. Done. You don't need any other. We didn't expect much anyway. Circumflex was the plan issue, but you want to complete, can do a 2.
Okay.
Yep. Or even 2 to 3, yeah. ठीक है. But also you could do it, just take the AR2, take the right picture and use the AR2 for crossing the valve. So one less catheter exchange.
No, 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 no.
Simple. You don't get too crazy. Simple AP even.
This one,
Yeah.
one injection is good enough.
Yeah, even plain LA is good. Okay, done.
So in the same, you can put a amplage wire.
Because now key is that we had to put our,
Large.
we decided that no, we'll go with the sheath length, but you still have to put a bigger sheath to create the track. Yep. Low mag.
Low mag out. Yeah. Okay. So can you give us dilators first?
Before the 14 French sheath.
Yeah.
Yeah. But you need some dilator. 8 is already done, 10 or 12, whichever.
10 or 12, whatever is there.
What is that, 12? And if not calcify, you could go directly at 12 also. But that's okay. Serial dilatation, is nothing wrong in that. Yeah. Good.
Yeah, you can give direct 14 also.
14 will go. Yep.
So the 14 dilator is the same sheath dilator that we are using. Yeah, I insert it all the way and always under fluoro. Yeah. No, it's like because you can see how the catheter is going through. That will be a big advantage. Yeah.
And that is why pre-procedural planning with the CT angio of the vascular access along with the tower planning, the sizing and so is both are important. So here you know, straightforward, a small vessel but straight.
So whenever you are using a Cook sheath, you should keep in mind, if you just push, when this hits the artery, this dilator starts coming out. So what you do is, with one hand I catch over here and another hand I just go down. Can you show us down the entry point? Okay, and always rotate and go, because okay. Okay, can you give me the TPI, please?
Yeah. Good.
Can I have a plus?
And the key is that you keep around ACT around 300.
Plus.
Yep. Good.
Okay.
Let's put a pacemaker now.
Now I'm going to put a temporary pacemaker. Can you give me the balloon, please? Okay.
Inflate the balloon now.
Inflate the balloon.
Yep. No.
Yeah, we
I
use
mean, it's
balloon
always
tip.
better. It's called
It's
less
always
perforation. There we use nowadays called tempo lead. Tempo lead is the little screw at the tip of the pacemaker so it doesn't move if you are leaving it for next 1 or 2 days. Or two.
Slow down. Balloon out.
Yeah, that's why the issue is so that you leave at least half inflated, but you will test it. What happened now? Why is not going?
The wire is not going through, so let me just see what is the issue over there. We never push in TAVI because pushing creates more problems. So if you have any problem, you can just see where.
You will never be able to see the way.
Yeah.
Okay, that's one thing. Take this out. You see the balloon inflate.
Uh,
Usually balloons should not be, and what I do is basically is we have some forceps, right? Make a little more curve. Okay, inflate now. Okay, deflate that.
yeah, it looks like there seems to be some
Then we puncture on the right side.
IJV access is there. So let's put from the IJV, I think.
And okay, inflate once again, balloon. And usually vein should not be in trouble. Huh?
She might have some stenosis because of that.
Because she had a surgery also.
Yeah.
Deflate now. Yeah. Okay. So
We put it from the internal jugular.
So IJ always there. So in this particular case, many times we have to leave this anyway.
Okay. Until then, what we are going
I
to
mean,
do
sometimes you can do, but you try to avoid because that's where the vascular
we'll put in
complication
the
increases.
other things. What are you going to? Can I have the pigtail, please? So I'm putting the pigtail through the 7 French teeth that I have put in the femoral artery, and this pigtail will go into the NCC cusp.
Yeah.
So as I reach on the top, what I do is I come back and just give a small anti-clockwise turn and go down. That's put the pigtail directly into the NCC. So this one now I'm going to connect to the injector.
Okay. What do you need? You are okay? Oh, you're still.
Back.
Two. Why that?
Okay. Okay, fill back the catheter, please. Yeah.
No, you'll see it in the LO view usually. It will go to the lowest side. That you have to adjust it. Actually, to really go all the coplanar would be RO, but really
Clean
to
it.
the lower one
What to clean?
to go, LO will be very nicely, will bring it down to all the way down.
Can you get this up? Yeah. We usually keep that because at the end, if we don't need a pacemaker, we just remove everything. If we need a temporary pacemaker, we put it from the top because it is more convenient for the patient later on.
नहीं वो चेहरा ढके नहीं बस but that's it. Yeah. Good.
Okay.
Want to leave half?
Half, sir.
Okay. Let's test the pacemaker.
Let's test the pacemaker. And
because secured pacemaker is very important for the deployment of TAVI valve at that time, and of course some cases you may leave it for 24 hours when high chance of conduction disturbance is later on.
so now I'm going to take a catheter which I'll be crossing the valve, with which I'll be crossing the valve, and this catheter will be either AR or AL, whatever.
Although it's a short route, what do you have? AR2 or AR2? AR2 is better.
AR2 is no.
Yeah.
Yeah, pacing is good.
No, AL is to the larger. So to small. The small is, but even very small, you can just go with the JR. But AR2, in the larger one, AL.
Well. Okay. Many times, like you can do an angio, root angio to see actually how the valve is and everything. But if you can as well try to go down directly, cross the valve, you'll save some amount of contrast over there.
No, but you have to do aortogram now anyway. Right?
Yes.
When do you want to do aortogram?
So you can do it now.
Now, yeah. Let's do the aortogram. So make sure sinus is there, so you have, and the view
one
which you are
mag.
going to deploy.
1 mag up, please.
Yeah. Which
Okay,
view?
can you come to the RAO caudal view? Cuspal overlap view.
21, 26.
21,
Always go to the
26.
view which you are going to deploy the valve. So, yeah, that's right. Yeah, based on the CT recommendation.
Okay. 1 mag up. Yeah. Ready? Okay. Inject.
Good. It's in the non-coronary and good position.
And good position.
Yeah. Okay. Go back to little LAO, right? Crossing should be in the LAO.
LAO.
Otherwise, you'll not know the catheter going into the RCA. your wire.
Okay, I have already crossed the valve.
Yeah,
Save the fluoro.
good.
Can you come to
No, first we are going to use with the exchange length.
We'll use a exchange Teflon wire, normal Teflon wire, because confida you are supposed to put only on the pigtail.
Yeah.
So sometimes your wire may not go to the apex, LV apex. So what I do is I give a clockwise turn the catheter, and very beautifully you can see the wire goes to the apex.
And this will always cause some PVC, which is okay.
Yeah.
All physiological. Oh, valve crossing is, as I said, that you keep rotating the tip of your catheter, whether it's AR2 or AL1, towards where it's bobbing, and use the straight terminal. But keep changing the position. So many times the wire goes and catheter does not go, then you rotate and you are able to advance.
So in this case, I had the advantage because I did it in a possible overlap. I can see that the non is here, right and left is there, and I have a small opening over there. So I knew exactly where to rotate and where to enter.
Yeah. Very important. That's why I said that you need to do that aortogram, so it gives you idea. Because rather than keep trying, you have some idea where it is. Many times in the very calcium valve, you can see it opening. But now you are all the way to the apex. Now you put your confida.
So now we are going to do a hemodynamic measurement. We'll see the gradient. We'll see the LV-EDP of this patient, because at the end we don't want the LV-EDP to rise.
Good. Okay.
So can we see the hemodynamic monitor? You can see this patient has a huge gradient of 50. LV-EDP is slightly on the higher side, despite having no AR. Okay, so now I'm going to place the confida wire.
Okay, the valve is ready. At this point, you have to make sure the valve is ready. Ready, okay.
So while I place the confida wire, I will never go till the tip, because this wire will jump out. So half in, I just push the confida wire.
Keep a forward pressure on the catheter pigtail, otherwise it will going to push out everything.
So once the wire reaches the tip, I start pulling back the pigtail.
Yep. In a small cavity, there is another wire called safari. A small ventricular cavity. The confida is good for all, but in some small cavities, then we have safari. It has the same loop, but it's the tighter band. I don't know whether safari is available here.
So now we are going to
other
the
one
valve
side only, I did not-
inspection before we put in the valve. This
No,
case, as
one
I
side
told,
only.
we'll be doing a direct implantation.
Yep. Okay, so now we talked about we are going to go sheathless, which is the inline sheath we call.
AP. Can you hold the wire, please? Because the wire may get pushed out. Can you hold the wire, please?
Up.
I should put it slightly above, because, yeah, this is good enough.
Yeah.
And we can see all that is required in this itself. You can see the valve is loaded very well. So we'll keep the valve on the table, because we are going to do a direct implantation in this case. Mag down, come to AP, up, mag down, show me the, okay. So, up.
What was the ACT before?
No,
Huh?
not that much.
Give 2000 of heparin. Okay. Oh, repeat
Okay.
it.
So now I am pulling back the seat.
Take it from the vein. Good. Make sure that you're paying attention to the wire tip. The wire is not coming out. Good.
Okay. Let's put in the valve. Take the valve behind, back, back, straight.
We can take the vein, the ACT from
Down,
there, right?
down.
Okay, good. Okay. They're going in. Keep the wire taut.
Some difficulty is there. So source down, please. As I told you, the femoral artery is just 5.2, 5.3.
Pull the wire a little bit.
Hmm. Okay. I can rotate the seat. Okay.
If you have trouble here.
So we have a trouble over there.
Question is, you put a 16 French sheet.
Can we have a 18 French dilator? We'll remove this. Okay, show us the wire in the LV, please, once.
Get the 18 French dilator.
Wire in the LV?
Good.
Okay. So I'm coming out, please.
No, but let's get the dilator ready yet. Good. Ready? Okay. Advance the wire. We're coming out.
No. It's a
Good.
okay.
Okay, we need a little more sedation to her. Keep it low, Max, so we can see the femoral, this catheter, iliac area, and the wire.
Okay, can you show us down, please? Wire
Wire is good.
down, down.
Good.
This is the 18 French. It goes in smoothly. So we have dilated the artery adequately. LV wire once.
Good.
Okay.
Go below.
We have a problem over there, I think.
Other question is, do we put to the 18 French?
We'll have to put a 20 French. This goes to 20 French. The 16 French device. We can,
Hmm?
so do you have papaverine? Papaverine?
We use there is a thing called rotaglide. We use there.
I think will come out.
Hmm?
It's not going to.
Okay, good. That's coming out. No, but let's decide what we are going to do.
So
First.
we'll dilate the. We'll just put in a seat, see what is there. If the artery is okay, we are going to give some papaverine, some dilator. and then go with the seat. So usually it dilates up there. Actually, there is no much calcium over there. We can even balloon dilate it if required.
Or why don't we just go with the 20 French sheath quickly?
Yeah, 20 French seat we can go with.
Yeah.
And
Where we put a dilator 18, what dilator we use?
we use the 18 dilator, sir.
We have 20 French sheath. You just leave it there, otherwise it will bleed. You want to see again? No, right?
No, it's not going to, sir. It's come out and
No, but
back the 14 French.
okay, let's get the sheath ready. We put the sheath back. No, but they're not finding 20 French sheath.
Invitable, not. You don't have any. Okay, let's take a 18 French seat and see how it goes.
Okay, give us the 18 French sheath. What is this? Okay, we have it, 18 French.
Okay.
Let's put the dilator.
Hmm?
Good. Okay, we are coming out.
Swash up, above.
Good.
The LV, please.
Good. So far, good. You can advance actually wire a little bit. No, on the top, show it the top. Good, 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 good. Other question is that do you want to put a lender kush wire?
Yes, that is the other thing that we can think of, putting in a London coast wire and just
Yeah.
trying to cover.
Yeah. We have the lender kush wire. So you need a little stiffer wire to go through it. Although let's try this one first once again. Now 18 French hole we are making.
Can you show us
Go
down?
below. No?
Not passing through.
The dilator we already put. Now we are putting the sheath.
I have a trouble going with 18 French.
Okay.
The
So
artery
let's
is-
take it out. We
let's
put a
take it
14 French sheath back and we use the lender
What
kush
we
wire.
can do is we can pull out the catheter and give some NTG or something so that it dilates the artery slightly.
Okay.
So we pull out the dilator. Just a second, sir.
Ready? Good. Good. Okay. Now, sheath is in.
Yeah, citizens.
Good. So what we need to do now, we have the,
NTG or something like that.
what is this? Not flush. We need a INTG. Okay. Now, what I would say, let's get our pigtail again and get the lender twist wire.
Yeah, that's another way.
Yeah. Yeah. You want to give NTG? But blood pressure will go down. Huh?
Someone on the wire? Can you show us the
Go up.
Go up, LV. Yeah, perfect.
Okay, let's get
Let's
the
take the
Lund
Lund request wire.
Okay, make a more curve, you're good. That's
This is
good.
good, sir.
Good. Good. Okay. Okay, ready?
Yeah.
Okay, you're going, taking out, now using the Lund request. We gave the NTG already. We gave it already.
Little difficult to push through. Okay, now probably the femoral artery is not conducive for the pro. Can downgrade to R if required.
Okay,
Because,
go to the
that will-
14 French then.
That will
Yeah.
be a true 14 French, and that will go through.
Okay,
So we need to load the R. So we'll wait until then. We'll remove this and pull back the seat.
And you-
This 14 French seat.
yeah, let's put a 14 French ready. So despite all the efforts, it's
Yeah.
not going, so we go to the 14 French.
Okay.
No,
Can you
let's
show
get
us
the sheet
down?
ready.
Can you show the LV, please? So the wire is coming out,
Advanced
so be
wire, yeah.
careful with the wire. Okay, what
Good.
we'll do is, yeah, that's it, the wire, let it be over there. We are coming out with this valve.
Eighteen did not go. Don't push.
So
it.
down, so down,
Good.
no force.
No force. That's the key.
That's the key.
We tried gentle force. Some force has to be applied, but gentle. And we saw it, it did not. So you stop and go to the 14 French. Your pro, evolute R and pro. Pro is the 16 and R is directly 14. Huh? Okay, go.
So show us down, please.
And we'll go back to our regular wire, right? Or you want to leave the
Yeah,
pigtail?
I want
No.
the regular wire,
Regular
because
wire, yeah.
that is good enough.
Yep.
We need-
Get back the pigtail now.
So show us the LV, please. The left is smaller than the right. We have already seen on CT,
yeah.
so there is no point in going to, yeah. 4 mm only,
Yeah.
one place.
Left wire is smaller.
Yeah,
small size?
The fibrotic, small size femoral artery?
No.
No, we don't do all those things because
Unless there is a stenosis, that's a different
that's
thing.
the different thing. Can you show us up?
Go up more. Calcium tahin, no, just a small size. Yeah, it was just 5.5.
Some amount could be radiotherapy induced fibrosis and all those kind of things.
Okay, make sure Medtronic team get the valve ready quickly. I know, but start with a 10-minute count now. 10 minutes for last 10 minutes. Yeah, yeah. No, but we'll go with this wire now.
Go with this one. There is no point.
The land request was the extra support. I mean, land request is a good wire, but that can cause lot of damage. So we try not to use it. We gave it a try that maybe that will help, but it not. Yep, that's it. That's a little different, even less support. But this land request, a lot of people use it particularly for 34 Pro, for 34 Evolve, because that gives you support. Valve moves less. And repeat ACT was what?
What was the repeat ACT, please? So in the meantime, we can discuss like what can be done if the femoral artery is smaller in size. We tried first going with directly with the inline sheath. Then we thought, okay, we dilate with a larger dilator. Despite that, the sheath did not pass through. So then we wanted to put in a 18 French sheath. That did not help us. So now what we are going to do is we are going to use a lower profile device. Initially, we are planning to put a Pro. Now we are going to use a R. That's the difference.
The Pro, because extra skirt, is 16 French. And original is 14 French. Direct inline sheet. Lefty. Huh? It take 10 plus minutes. नहीं वो तो लोडर है, वो तो लोडर है, वाल तो आए नहीं ना अभी. Yeah, so I think in retrospect, if you need to reanalyze, once the vessel size is just about 5.5, you're probably better off go with the R rather than Pro. Because we need, to have 14, 15 French, 16 French, you need clearly around 6. It was 5.5, 5.4, right?
Yeah, 5.2, 5.3. So
you're making it to 16 French was very tight fit. We learned it here. So 16 French was not the right here. Huh?
The
Did
18
not.
French
That's
dilator went through. The
But not the
dilator will
sheath.
go through because it's more hydrophilic and it doesn't have that one add-on thing that comes up. The dilator is true internal diameter, but with the sheath it becomes the outer diameter that we'll have to think of. So that's
And that needs 6 millimeter. 18 French to go in, you need 6 millimeter vessel. And we know it was not 6.
Dilator 20, I doubt it would have gone in this case because
Possibility, but not the sheath. Since 18 French sheath did not go. Yeah, no, definitely. Dilator even higher size is better than the smaller sheath. Yeah. We have some PVCs because of the wire, or it's the pacemaker.
it may be the wires that we'll let it. It's the pacemaker, I think.
No, it has hold it. If you worry about.
If the pressure would have gone down,
Yeah.
we would have definitely gone from the other side and checked.
Yeah.
But the pressure
Yes,
is
definitely.
good, so we don't think.
And the key is same. You put some pressure, but not forceful, because then it will tear open the vessel. But they have the additional valve, right? Regular. It's in the truck down there. Where? Huh? The question is in the alternate routes.
We could have tried subclavian, but again, due to the radiation, probably that may not work out because that will also be smaller in size. Always creates a lot of problem. So this, we know that the valve will go through this because already a 14 French device has gone through, 18 French dilator has gone through. So we have a lower profile device, we'll use that lower profile device.
Yeah, the other approaches subclavian, direct, or the carotid. There's some data on the carotid. I don't know what size carotid this one is. We have done 3 cases with the transcarotid, but clearly they did not have any disease. Uh, they actually have from the France TAVI, they published the data of 100 plus cases. So selected cases is fine. We used to worry about having dissect the embolism and CVAs, and so it's about the comparable. But then very selected cases. Last year in 2021 at Sinai, we did not do any non-alternate access. Last year we did 453 TAVI, and all were transfemoral. 91.5% percutaneous and about 8.5 cut down. But many times cut down, you use a shock wave, but there is a disease there. If there is a disease, then you use a shock wave, and then you make your way through. But 2 years ago and then 3 years ago, we did transcarotid. Subclavian, we published the data a long time ago, but it's kind of abandoned now. We're not using subclavian because valve has become so smaller, up to 14 French. It's okay to go through the femoral with one or other way approach, either cut down. But all alternate access still have higher complication than transfemoral. Yeah, cut down. Yeah,
Transcarotid is always a cut
Cut
down.
down,
So transcarotid, we see which of the carotid is more aligned. 90% of the time we choose the left carotid, only 10% of the time we go to the right carotid. So it's a
The problem with the carotid is your delivery catheter gives a lot of trouble because not enough room.
Yeah.
So there's a lot of manipulation required. Half is still sticking out and so and so. Yeah, so I mean, one is that it's basically that make it smooth. So what we do quite a bit commonly in these tough cases, this kind of case small, use the rotaglide. Rotaglide is the emulsion of a fatty emulsion which you use for the rotablator and put in the mixed bag to decrease the heat. So we use rotaglide. Then other papaverine and so is available here.
yeah, papaverine is there.
Yeah, so that is same vasodilator to do. But more important, if it's an organic disease, then use a shock wave. Shock wave definitely will open the lumen and get your device in. So of shock wave use about 5-6% of cases, and that definitely helps. So that no need to put any stent further, shock wave balloon, got your work done. And actually, peripheral shock wave cost is lower than the coronary, half the price. I don't know what is in India.
They give for the same price over here.
Same? Because catheter there is 4,700 is the coronary and 2,400 is the peripheral shock wave catheter. For the peripheral. So that is the only one. And then stiffer wire, which we use, try to use a Lenderquist, which much stiffer wire.
Yeah, that is what I did. I pushed the pigtail, kept it out, and then I went till the top of the pigtail and started pulling back the pigtail. So that's pigtail body.
Because when you advance the wire, then it will fall, automatically will fall into the apex.
Yeah, so the pigtail, till the tip we push the wire, and then we actually what we do is after that we start pulling back the pigtail. So the wire will remain in the same shape that the pigtail was. Lundaquest is a stiffer wire, 68 grams. So you should never push a Lundaquest wire. That you should keep in mind. If you have any doubt that the LV cavity is small, reshape the Lundaquest wire in such a way that the junction point is actually shaped as well. As I told you yesterday, if the junction point hits the LV apex, you are going to tear open the LV apex. That's
I see. Okay. Yeah. Good. Yeah.
So that's why, Lundaquest, you should be very careful with the Lundaquest wire. Now, Metronic, sir, is coming with a wire which is heavier as Lundaquest, I think. They are coming in a pigtail shape.
It is the pace rhythm or patient own rhythm now? Hmm?
No, it would, again, you'll have dilate, that artery again has to get dilated. That's no other zoom. See, again, the Python sheath is 14 French sheath only, if you see. But when the valve goes through, the valve dilates the artery. So it goes up to 20, 22 French again. So in that case also, if the artery is 5.5, we face a lot of problem in pushing the valve. Lot of problem.
Yeah, whether Python would have helped here. May dilate because the sheath will dilate further. We have the Python sheath.
Python sheath? We have, I think. But yeah.
If we have the 14 French, we can try once. Although the valve is coming slowly. Yeah. Make sure the hemodynamics are good and ACT was 400 plus, huh? No, calcific, because if the vessel size is big, you can crack the calcium and vessel will increase. But if the vessel itself is 5 millimeter, then you're in trouble. You're calcific and 5 is the trouble. Yeah.
So another 5 minutes. That's the difficult.
Yeah, yeah.
Because we don't have any data on that.
Yeah. But same. Either, yeah. To the calcific. Yeah, that's with the same principle, yes. Answer will be that fibrotic will be more yielding, less perforation compared to the calcific. Yes. So these are the various options which, the troubleshoot which happens. Things were going very smoothly, but did not predict. But I think the takeaway lesson should be that if we have a less than 5.5 millimeter sheath, do not try pro, go with the regular evolute. R, which is 14. So that there, it's just about 5 will do the trick. Now, if you want to give some more medicine before we go in,
Yes,
you can
sir.
still give
While
it.
we are coming out,
We have these are the nitro, we said.
if we have a papaverine, sir, can you load papaverine 50?
So we have not used the papaverine, but we'll ask what the dosage are.
I usually use at 1 milligram per kg body weight.
Good. Give us the syringe.
Okay, we check the valve. So can we have a sterile state?
We have it again, it's still here.
Yeah, we have it, sir.
Yeah, we have the sheath.
We have the seat, so no need of seat.
This is also remarkable. The signs that the valve is deployed, the crypt right in the cath lab, get ready.
Huh? क्या दी तूने? हम्म?
Yeah. Yep. क्या है? ये क्या है? तो बस दोनों दे देंगे.
दोनों दे देंगे, कोई नहीं.
No, we brought one earlier. Then why did you give second one?
क्यों
I
देना
know,
है?
but not at the same time.
Not at the same time, no?
Now we give the flush first and pepperine second.
नहीं,
कौन
we
सा है?
don't know which one is which. नहीं
She
नहीं.
knows it. Yeah, which one is the what?
No.
This is what? Flush.
You cannot be 100% sure.
No, she
So
knows
that-
it. She is 100%. Good. She is confident, my friend. She is confident. Good. All right, how much more time?
Done, sir.
All right. Let's start
So,
giving it.
this looked like quite a simple case, but important lesson to learn, I think.
You give all throughout.
Let me pull down and
Hmm.
let me pull down. Source down, please. Down. Suro. Down. Oh, seat we need to see. Yeah.
Yeah, good.
Okay.
Okay.
That's good enough. First, we'll check the valve and then we'll get this it out.
Yeah.
Okay. Give us the valve. ठीक है, that's okay. Okay, magnification up. Magni, up.
Good.
Okay, I think it's a very well loaded valve. So we just keep the valve over here on the table.
Hold it.
Show us the LV. Show us the LV.
Good.
Okay.
All right. Take two. Now we are going with the regular, our evolute R, which is the 14 French. So by definition, less than 5 millimeter vessel will accommodate. So Medtronic side up. M, good.
Can you show us down?
Good.
Okay, you can see
Yeah.
very easily this valve passes through. You can come
Yeah.
over here.
Yep.
Okay,
Okay.
show us above. Yeah, just wait. LAO 45. LAO 45.
Yeah. But deployment angle was 21, 26, no?
We need to cross the
Yeah,
arcs.
right. Yep.
So we cross the arcs in LAO 45. Okay,
Ready?
ready, sir?
Okay, so just rotate, keep push and pull.
Mhm. Okay.
Pull the wire a little bit, good. We are crossed.
We have crossed the valve. Come to the deploying angle, please.
21, 26, RAO 21, caudal 26. Good? Good. Magnify.
And the pigtail has moved, so what it's entangled. So I come back with the pigtail and then again go down.
Counterclock and go down.
Go on counterclock and go
Okay.
down. That's the perfect place, I think. So I think that's a nice place
Yep.
to start with. Come caudal slightly.
So the
So
ring
we-
has to become
Straight line.
a straight line.
Perfect.
Good.
Perfect. So
But
can
ठीक है,
we
ठीक है,
take a injection? 8, 10, 800 psi, 8 ml, 8
That
the ring.
See that? That. Good.
Okay, let's inject. I think this
Good.
is the right place to start. So I'm starting to open the valve now.
And Sanjeev, you are holding the wire, right? Good. And now you start the pacemaker soon. Yeah.
So one more injection we take to confirm where we are. Sir. Inject. Yeah,
Good.
I think it's a good
So far,
position.
good.
So far, so good. Okay. So
Yes.
pacing at 140, sir.
Okay.
Okay, I'm starting to open the valve. I think we may have to go in slightly.
No, that's good.
It's a very nice position, I suppose.
So 80% you
Pacing
deploy,
off.
then you stop. Pacemaker off. Don't complete here. Yeah. Good.
Please go to LAO.
Take a picture. Go to slide LAO.
A
Good.
nice position, I
Good.
think. Dr. Hemant, what do you say? No leak.
Yeah. Okay.
Trivial one. Okay.
Take a picture.
No, no, sir.
No?
We have not gone into. Okay, Dr. Hemant will tell us by then what is the gradient like. Hemant, yeah,
Yeah.
that is what
Yeah.
down. Usually in between the pressure will go down because once it makes the annular contact, there is no cardiac output over there. So just wait for another 10-15 seconds, it comes up.
Oh, yeah. Within 10. Good.
Okay. Can we
Okay.
go to LAO, please? That's it, that's it, that's it.
Very good. Take a picture.
Mag up, 1 mag up. Sir, and we can take a shoot. Inject.
Very
This
good.
looks a very good position, no gradient, and the rhythm has also been good.
Go to 150 again. You pull the wire, make it center nose bone.
Yeah.
150
Okay.
again. Good. Deploy.
Okay,
So we're going
slowly.
to final release now. With a little forward pressure slightly. We're going to spring back. So you just little forward pressure.
Okay.
It's
We'll
still
push
attached.
in slightly because we want to see whether it is still attached.
Okay. Off pacemaker, right?
Push in slightly. Off, pacemaker off, please. Push in slightly, sir.
It's still attached, right?
We'll just turn it. Still attached. No, no, it's pedal looks attached. Can you centralize that, please? One is still
Is it
attached.
attached or no?
I think it is out already.
It's already, yeah.
No, no, it is still attached. Something is still not good, sir.
It's still attached.
Still attached.
Okay, save the fluoro. Good. You're pushing it.
But the eyes are out, sir.
Hmm?
Both the eyes are out.
You want to?
The catheter.
You need to go to some other view.
Some other view, can you give us?
Okay, should I pull back the pigtail?
Fill. RAO, we are not seeing the other side.
No.
And now it looks like it is
Yeah.
given up. Can we go in, sir? No, it's given up now. Okay, so now I'm coming back on the wire, and what I will do is after it comes in the center, I'll push back the wire. Okay?
And then you marry it now.
Yeah. So someone be on the wire, please.
Okay, in case we have to push dial it, no, because we have to now combine it. Yeah, advance, yeah. Marry two ends. Yeah, good. So now in order to take
So
out,
now can we have the 14 French seat ready?
let's get a pigtail. So do the autogram, right?
Yes, sir. Ready for an iotogram?
Now what we're doing the aircraft first?
Hemant, 1 second. Can you give us a time for iotogram? Inject. No AI
Very
at
good
all.
position.
Very good position. If there is no gradient, we just come out. Hemodynamic. Can someone hold the catheter over there? No.
We have the sheath ready?
Yes, sir.
Good.
Hold someone on the wire. Take this out. Frame.
Beautiful.
Give me the seat. Okay. Yes, the 14 seat. Pigtail, catheter, keep ready. Okay. So now what we are going to do is we will just come there and remove the. Okay. Let's take the pigtail.
Now echo will tell you about 5 to 10 millimeter gradient with the our hemodynamic usually is 0. Yeah, done. Welcome.
Okay.
There.
You can see the gradient is 0.
Plus there. Good.
So you can see the gradient is 0.
The hemodynamics is always 0. There is always 5 to 10. Good. Okay.
So what we
Fluoro
are
will
going-
take it out now.
We'll take this out. Give us the wire.
No. Picture will come out by itself. Yeah. Now the most important
So now
thing
we are going to close the femoral
Yeah. First
and then come out.
go below.
Okay. Remove this. Give us the dilator, please.
We are putting the doctor now, right? Radial? you're doing? Oh yeah, radial. Now it looks like a pace rhythm, right?
It's self-rhythm, sir, with LBBB. Wide QRS.
Because not uncommon. You remember a small valve, a small root. No.
So now what we are going to
We
do
did tell
is we
that
have
it's
a,
15% chance
if you
for
can
pacemaker.
see, we have a white one and a blue one. We don't touch the white one.
Connect one of the
We
pressure.
just take the blue one.
Keep connecting when you are doing all this, keep your blood pressure connected so you have your hemodynamics monitoring. Yeah, we may need little fluid, maybe little extra fluid. Pressure is on lower side.
Can you show us down? Give me the Lima catheter for the groin. Turmoil.
So this will tell us any injury or any things we had and what would be the.
Can you show us down, please? So what I'm going to do is, before I pull out the seat, I put my catheter over there so that okay, I think I'll pull out slightly
You
more.
have to pull back your dilator. There is not enough room, my friend. Not enough.
And very well for this. I don't know.
No, Lima. Lima is very good.
Lima is perfect for this job. Okay. Someone can inject while I pull it out. No DSA, please,
No DSA. Yeah.
because we are going to track the catheter as well as everything.
Okay, no DSA.
Okay. While I pull out, sir is going to inject so that we know, okay, sir, whether injury is there or not. Okay.
Can't even see the flow.
No, he's catching it. You can leave that one. You can leave that one. Everything. Yes, sir. Now, sir, inject, sir.
There's no dye.
Okay. Sanjeev, please leave it. I'll take care. Come out, please. Come out, please. Okay, give me the knot pusher, please. Can you press? No, from this side, can you press? नहीं प्रेस करना है प्लीज. But definitely we know that there is no lesion on the top, and yeah, we can take it. So, can you get a 8 French angiosyl ready, please? Yeah. Yeah. Okay. Okay. Can you show us the femoral head?
There's
Follow
no-
it up, please.
You can
Once.
always do a little balloon, dry seal with a balloon
Come.
if you want to.
Okay. Can it injection, sir? Inject.
Catheter came out or what?
The
Catheter
catheter has come out, I think.
Catheter has come out.
Yeah, the catheter is already down, sir. Turn over. Okay, sir.
Ready?
Since we have caused a lot of injury to the artery, we just want to follow up and see how the artery is. Okay.
Good.
We can leave. Yes, sir. Inject, sir. The artery is still flowing. That small
Very good.
leak is because I had left over there. We have only one proglide. The moment we put in a angiosyl, that is going to stop.
Good.
So, angiosyl, sir. But
But you see, nice, no injury. So that's same.
The moment you start pushing with any of the catheter, you are dim for some kind of complication. You saw we did not apply pressure anywhere during the procedure. We just used the available resources to complete the procedure. So you should never apply force any place. What do you say,
Yep,
sir?
absolutely. So that is the take home message. Big message here is it delayed it, but we went step by step and went to the what is available options. And one option basically was that go with the smaller device, which is 14 French compared to 16 French. Yeah, the disadvantage that you lose that paravalvular leak, but luckily in this case,
There
because
was
the
no
size,
leak.
there was no PVM, despite no pre or post dilatation.
Hmm. Usually, I have seen only once it has happened, and then I had to cross and I had to balloon it up. But usually, it doesn't happen. You can see the artery is perfectly fine, despite knotting it up completely. Hmm. Yes, of course.
Yeah,
Of
oh,
course.
definitely.
Definitely.
Yeah.
Can take one more injection.
And many of the small arteries, actually, after one pro glider, you hold it for 15, 20 minutes. You reverse it anyway. Right? Are you going to reverse it or no?
Yes, sir. We are going to reverse it
Yeah.
completely.
We can reverse now. We've taken all the pictures. Oh, there's a little narrowing now.
There is a narrowing, but there is no flow limiting. I think we can leave it, sir.
Hmm?
It will get better with time because this is with the spasms. I think it is okay, sir. Yeah. Okay. नहीं हो गया. We are going to keep the pacemaker for 24 hours,
Yeah,
sir.
yes.
There is no change in rhythm. Despite that, we want to be sure. And tomorrow, we'll make her walk around. Day after tomorrow by evening, she will go to the room. Day after tomorrow or the next day, we'll discharge the patient.
Yeah. And if there is something with the groin, then we may have to come back and do a balloon. Right? Question, should we do the balloon now?
Sir,
Hmm?
looks okay, sir.
I mean, usually you see a little bite, but this is a little more than usual.
We can do a balloon right now itself for the peace of mind we have.
Yeah, but-
Okay, give us the same exchange length wire.
Yeah, we already have every device.
Everything.
Just do the balloon now, because rather than coming back later, but just a soft
Exchange length thermo wire.
five.
5
No,
mm
but I think
balloon.
there is a little bit of constriction by the catheter. So doing a little balloon, low pressure, small size. What size balloon you'll use? 6?
We'll take 5 or 6. That is good enough. 5 is good enough.
Yeah,
in
5.
this, yeah, because the size of the artery was just 5.1 up there.
So key that we don't want to go higher and rupture, but usually doing a balloon is okay. But so whatever constriction has occurred, it will just loosen the knot a little bit. It's not going to crack it unless you go to high pressure. So just loosen the knot. That's what we want, because this is a little more than usual. A little bite is acceptable. This is what angiographically, once you see 70, 80%, I think you have to take care of that. Yeah, no, but no, we do all the
We
time.
always do that.
Yeah.
In our center,
In these cases, because remember,
It's,
these patients will
each
be
case.
symptomatic. These are things which we miss it. Yeah,
देखो,
you always want to
Tiju,
do
show us down.
yeah, mandatory part that you have two things you have done. One, you have attained the
Okay.
complete seal. There is no
Well,
leak, there is no pseudoaneurysm, and there is no
Go in.
constriction.
Go in. So follow the wire, Sejo. Give me a dry gauze, please. Okay, catheter out. Balloon. Give me a wet gauze.
5 for right?
5.
Yeah.
Yeah, 20 is good enough. 035 compatible, huh? This is barred. So this is pinched at the north side actually. Yeah.
And I'm saying that anything of just about 5 millimeter, I'm actually very proponent of you put one per close, hold
Sir has always been a big proponent.
reverse. One per close is good enough. In 15 millimeter, 5 millimeter size vessel. And this is all because of combination of both the knot and the. It could be just the angio seal, so foot plate will just push it out a little.
Wire on the wire, someone please keep it straight.
Good. Now you cannot see because it's the balloon alone. There's no sheet.
Yes, sir. We don't have crossover.
No, but go to the previous picture.
Can you put the picture?
Yeah.
Yeah, that's why we are just.
This is it. Yeah.
Yeah, we are in the right place. Can you go up? 2, 4.
Good.
Yeah, we saw the
That's it.
waist.
That's it.
Well, not much.
4 is good.
We can wait for some time. We can pull back the balloon, pull back the wire. Through the balloon itself, we can inject and see
Good.
how it is.
Yeah.
Yeah. A single flow guide sometimes is not.
No, but
enough.
on point is you reverse also. Have you reversed it or you reverse? Okay.
Okay. Balloon down?
Yeah. Good.
Yeah.
No, but I agree with Sanjeev. One proglide usually is not enough, but in the small arteries and so this one pull back. You did a proglide and reverse
okay.
and wait
Pull
10
back.
minutes with the pressure.
We can inject through the
Good.
same
Yeah.
balloon.
Take the wire out.
Take the wire out and inject through the lumen. Okay. Seen. Perfect.
Done.
Yeah.
Okay. Good.
Wow.
This is the conclusion of the case.
Thank you so much
Multiple
for being with
steps,
us.
multiple learning steps.
Multiple learning steps. The case looked very simple, but then we learned that sometimes because of the femoral, you can have a lot of problem, but choosing a lower profile device always helps. Closing with a single proglide sometimes there can also be some problem, but we can always take care of all kind of thing. You should be very vigilant. If you have done a lot of push and pull, then you will have to take an injection, see if any kind of rupture is there or not. If rupture is there, I always tell that you should have a covered stent in your lab. Immediately put a covered stent and take care of that. Thank you so much for being with us, and thank you, Dr. Saming.
Thanks to everyone and our cath lab team.
Thank you, everyone. Thank you. Uh, Welcome everybody. Let's start with the second case and from Internal Heart Care Center. Dr. Samim Sarma will be joining in some time. I have Dr. Sajib Sarma with me. Again, Dr. Navneet as anesthetist, Dr. Hemant will be joining us in some time. He is our echocardiographer, and we have a lot of other people around. I can see Dr. Ahuza over here, Dr. Bhavesh over there, and Dr. Azruddin over there. So I would request uh, uh, Chitresh to tell us about the case.
With breathlessness on exertion, which has progressed from class 2 initially to class 4 now over the course of past 3 months, associated with angina for past 2 months, for which she underwent echocardiography, which revealed LVEF of 55%, no regional wall motion abnormality, severe calcific aortic stenosis with a aortic valve area by continuity equation of 0.35 centimeter square, a mean pressure gradient of 81, and a Vmax of 5.7 centimeter per second.
Okay, this is the CT of the patient, and you can see there is heavy calcification on the annulus. There is also calcium that runs down into the LVOT, and the valve is a functional bicuspid valve. I can see the raphe. Probably when we balloon it up, that raphe is going to give up. The minimum diameter in this case is 19.1, and I think if we should balloon up with either 18 or 20 millimeter balloon. We can then take a 26 millimeter. We are going to then implant a 26 millimeter evolute pro valve in this case, because due to the calcium, we need an extra skirt to seal it off completely so that the patient does not have any kind of regurgitation.
This ascending aorta.
There is, as you can see on the valve, there is heavy calcification. The LVOT calcium runs on both the side. So we can expect either a pacemaker or a some amount of leak in this patient. But with Pro, we'll see that the patient goes with no leak at all. These are the angles, and you can see the amount of calcium going into the LVOT again on the first image. The femorals are good. The femorals are all above 6. So I think in this case, we are not going to have any problem with Pro going inside. So the plan is we are going to take the left side as the diagnostic side, the right side as the therapeutic side. We are going to put a 7 French teeth in the femoral artery, a 6 French in the femoral vein, and then we cross over, see the femoral head, take a puncture on the right side. So this is how we start with. So in the beginning, I always see the femoral head come out. Then we give a very liberal amount of local in these patients. Okay. As the femoral vein, can I slow down? Okay. That's the artery. Slows down. So a 7 French teeth goes into the artery. A 6 in the vein. Lima catheter. Lima. So Dr. Prem has joined in for this next case. Where? Okay, that's even much better. Goes directly into the common iliac contrast. Okay, can you focus on the femoral head, please? You can see the artery is large in this case. I'm going to put back the thermowire. The bifurcation is higher in this case as uh, Dr. Ahuja has told. So we need to take our puncture site should be at the top of the femoral head near the acetabulum in this case. Okay. Okay, out, table out. I'm going to hit this. I'm going to infiltrate good amount. Doesn't matter so much. Okay, can you sew up slightly? Okay. So the angle at which it goes is always 45 degree. So that, see where I'm hitting on the top. Slightly higher if you can see, because the bifurcation is low. The puncture looks good. We can come out with this thin. Otherwise, sometimes we end up having problem. No, the blade, please. The blade. So I put nick on the either side of the wire. Then I take a artery forceps again. Okay. I use the dilator to dilate all the subcutaneous tissue around so that my proglide doesn't face any kind of problem. Okay. So once the wire comes out from that, you can push the proglide down until you see the wire is just at the level of the skin. We pull out the wire and let the proglide just go in. You will see a spouts of blood coming out of there. That is the time we open this one, come back until and unless that sprout stops. and then we fire the toe glide, come out. Cut it, come out, hold that. The two sutures will be there, which I take in hand and then just place a artery forceps over there. Now I come out slightly, and through the two markers over there, we put back the wire. Okay. We confirm the position of the wire once, and then we just pull out, put a 8 French sheath over there. Temporary pacemaker. We can give heparin. Yeah, we need to check the coronaries of this patient because we have not seen on the CT. We have seen that there is some lesion on the coronaries. So before we put in the valve, we need to make sure left and right, Judkins. So me down, JR, JL, JR. No. Now inflate. So up, follow up, out, balloon out, deflate. Okay, half inflation. Yeah, that's it. Thank you. So now we give it to our hands, and I just artery forceps. Check the pacemaker after that. Out. Perfect, sir. Thank you, sir. Okay. Source. Okay. There was a lot of calcification in the coronaries. I was thinking there will be some lesion on the LAD, but it's, if the calcification is there, you cannot always quantify the lumen in the artery. So right one. You can give it the GR. Okay. You can see the calcification on the valve is already visible and it's heavily calcified. That's the problem with this case. If we are going to use a normal evolute valve, we might get some amount of paravalvular leak. So evolute Pro is the better valve in these cases. You can also see that bobbing of the catheter already. Okay, Somi. Okay, that's perfect. We'll keep the catheter and put in the stiff wire. Amplaz wire.
you'll have to use the pilot. Sometimes you damage this wire. Okay. Okay. Yeah, let's go. Okay, remove this one. Okay, can you bring down the magnification, please? We don't need so much of magnification for doing this. Give us the dilator. 10 French. Some dry gauze over here. Thank you. Okay, swash down. Give us the 14 French. Prepare the 16 French sheath, please. Sew me down while I go. Okay, the 16 French sheath, please. Okay, as I told you previously, we need to go simultaneously with both the hands. Sew me down. The entry point is crucial while you push the sheath because it should not damage the artery. Okay, that gives away, and then just by rotating, I go up. Okay, you can remove the dilator. Okay, can I have the pigtail? Pigtail. Leave it. Let's go. Yeah. Okay, let's connect it. A bit of a horizontal aorta, you can see over there. Okay, back. A lot of air is there, so you can take it back completely. Just tap once or twice, take it up, bring it down. Now we are going to take a AL1 catheter or whatever is there. You can give me. AR2 is also good. Okay. So wire then, okay. Push the wire. Okay. Magnify the image because need to see. Give me the straight tip term wire. You can connect the pressure line here, Prem. Hmm?
इसको 0 तो करना ही पड़ेगा. So I think we'll need to, okay, we have crossed through. Okay, you can see due to the calcium, it was extremely slightly difficult to push the catheter in also. Okay, can I have the exchange length wire? Okay. Now, this is a very heavily calcified valve with horizontal aortas. The catheter is hitting on the top, so I just rotate the catheter slightly and go till the LV apex. Yeah, we have a good amount of mitral calcification in this valve. Well seen on the CT as well. Dr. Hemant, the wire position looks good. Okay, great. Okay. Anything. The problem with the severely calcified valve, annular calcification that goes into the LVOT is that if you use a balloon, higher balloon, larger balloon, then there is a chance that you may rupture the annulus. So you need to be careful with redilatation as well. सीधा रखना है, straight. Yeah, you can take the light. Okay. Now we have the pictoline. We are going to take the hemodynamic measurement now. Flush it off so that okay. You can say there is a huge gradient. LVDP is almost like 20 in this case, and the gradient is almost like 50. So we are going to put a confida wire now. So as I told it, confida wire, we never try to come till the tip. We just put in and then use the pilot to go in. Can you get the screen slightly? That's very oddly placed screen. So you see, I'm pushing. As it comes on the top, I just start pulling back the pigtail, pushing the wire. Okay, Prem. Push the wire slightly. Perfect. Okay. So here we go. So we are going to check the valve before. Can you open the balloon, please? 1:5 dilution contrast for the balloon. That's always a debate. I think we'll go with the 18 because we want to be on the safer side. We don't want to rupture the annulus. No, nothing like that. Prepare karo. It's okay. No problem. Prepare karo balloon ko. Okay, can I have a sterile sheath? Okay, sterile sheath is here. We are going to put the valve and we'll check the valve. Ready with the valve? Prepare karna balloon first. Okay, just show me the valve. is perfect. Okay, I go cine because I can see both the paddles and both the paddles are in proper place. So it's a well loaded valve. We will give back to the valve and we'll take the balloon now. Mag out. Yeah, of course. And if it is not there, then we again ask them to reload the valve. Okay, ready for an injection? Same volume, something. Yeah. Go to the view. RAO. You can keep this view also LAO1 and caudal 14. LAO1, caudal 14. Ready? Okay, cine, inject, inject. You can see there is some AR, heavy calcification on the valve, LVOT calcium. On the wire, please. Okay, now I'm going with the balloon. AP Azov, please. Okay, we have crossed the valve. Okay, so now we are going to go pacemaker up to 180. And after that, we are going to inflate the balloon and then down. Okay, pacing on. Go up. Go up, no, down. Pacing capture नहीं हो रहा है. Okay. TPI has come out. Let me just push it back in. There's a problem with the sometimes. Okay. Now can you check please? Is pacing? Yeah. No, still not pacing. Okay. Just a second. Let's let the LV breathe. Okay, pacing on, sir. Let balloon up. Yeah, go all the way up. You can see the constriction. Balloon down. Balloon down, down, down. Prem. No, it's. Okay, pacing off, sir. You can see just by ballooning, the patient had a transient CHB. Okay, come up to the balloon, Prem. वायर थोड़ा सा अंदर पुश. So it's a 50 ml syringe that we take and we just go up. Yeah, just by the visual assessment. You can see that everything is opened up, the balloon is completely up. Okay, the valve on the table, please. Okay, now we are going to remove this sheath and take the valve directly, okay? Okay, Prem, looking up. Okay, sorry, it's not coming. कविता जी से पूछो. So we are going with the valve. The valve's this position should be at 3 o'clock position. Okay, let's see from. So can you just show us down? I'll tell you yesterday what I was saying, that hatchet marker you can see right now it is on the outer surface. The hatchet marker up there. Mag up, mag up, mag up, magnification up. हाँ, magnification बढ़ाना है सैजू. Yeah. So if you see that hatchet marker, it's facing outside, and that is what we need in this case. So the hatchet marker over there, outside on the outer curvature, and this port should be at the 3 o'clock position, so that there is a commissural alignment. That means the C tab goes immediately behind, and the left main origin is away from any kind of struts or any kind of not struts but any kind of skirt over there. Yes. So you can already see that the valve is actually horizontal aorta, is slightly horizontal aorta with lot of calcium on the leaflet as well as going into the LVOT. Our target over here is 3 millimeter, so that the skirt's maximum benefit, we can get the maximum benefit of the skirt. The depth should be in this case around 3 millimeter, 3 to 5 millimeter, so that the depth, ideal depth is 3 to 5 millimeter in Medtronic case. So yeah, so what we do is we position the valve at the level of the mid pigtail, at inside the pigtail, and then we start opening the valve, because we know that at that level it will slightly go in and go around 3 to 4 millimeter down, and the ring width of the delivery system. The valve will depend upon what size of valve you are using. In some it is exactly on the line, in some it is slightly below. So in 34 it can be slightly up, means in front of the thing also. Okay,
Alright.
can we have Dr.
ready.
Samim Sharma, who has joined with us, and we'll go 45 LAO 5.
You have done the post dilatation?
Yes, sir. Everything is done. Okay, so now I will just go through, and there might be some difficulty in crossing the valve.
Would you dilate it with a 20
Yeah.
or?
Sir, so in this case, you can see due to the non-alignment, there is some difficulty. I think we need to push it. Yeah, yeah.
We can go one more.
No, sir,
Back.
we can still go in, sir.
Yep.
It has gone in.
Yeah.
Some more. Mag करके रखो ना सीजो.
हाँ.
Show us the center. Yeah, some more, sir. Okay. Okay.
Okay, we are good.
We are good.
And
We'll
then
have to
bring back the
reposition the
pigtail.
pigtail.
Floor again.
Fluoro.
And go to our view. Implant.
Ah,
So
there,
counterclock
there.
and you go down. This
Yeah,
will be the
perfect.
non-corner.
So now
Go corner. So remember the ring has to become single.
come to
Cannot be-
that view, RAO 1435. Yeah.
अभी भी नहीं.
अभी भी नहीं आया है. So come caudal, some more.
Yeah.
Okay, some more caudal. Caudal.
Sorry.
Okay, it's
Yeah.
slightly difficult in this position, so we can go to that 114 view. 114 view. LAO 114 caudal. Caudal 14.
Caudal.
So it was difficult to have a view in so we are going to do it in coplanar view. Come caudal, caudal, some more caudal, caudal, caudal. Keep coming caudal, 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 caudal. Yeah, some more caudal.
That ring
some
has
more,
to become.
some more caudal. This is the horizontal aorta. Sometimes it is really difficult to get that
Good.
position. Some more, or you can go slightly LAO. Yeah, some more LAO, some more. Perfect. That's it. So that is the position we want. So shall we take an injection, sir?
Yep.
Okay.
Go.
Let's take an injection. Yeah, perfect. I think we can start from there.
Yeah.
What do you feel, sir?
Very good.
Okay, ready for one more injection to see the position? Inject.
Good.
It's good position, I think.
Go.
And what we'll do, 140 pacing, please. Okay, now slow. It's come out.
Good. Start again.
Okay, pacing off, please.
So see that jumped. Yeah. So restart again.
One more injection. It might be too deep. Oh, inject. I think we are too deep in, sir.
Good. Go.
Okay. Injection. Perfect.
Okay. Keep little forward pressure so that it does not jump out. Pacing.
No, we did it without pacing this time. And I think the position is good position.
Take a snake.
Okay, ready for an injection? Alex is out, so let's inject. Oh, that's a beautiful position, sir.
Good.
What do you feel,
Let's see
sir?
the echo. Yeah.
Let's see the echo. Yeah, this was a heavily calcified valve, so some AR we are expecting. But over a period of time, this AR is going to come down. What is the amount of AR you are seeing? Mild.
Good. Mild is okay because it still has to
Yeah.
be released. All right. So let's release and we go at the pacing.
Yes, sir.
Release it. Okay.
So,
Fluoro. Let's get a pacer 150. You pull back the pigtail, even you don't pull back, it's okay.
I
but you
usually
will
pull
yeah.
back, sir. So some
Go.
forward tuck,
Yep.
sir.
Good.
Pacing on, sir.
Yep. Little forward push.
Okay, the valve is
was
deployed,
the valve.
pacing off. Fluorosave. The diastolic pressure is good, so I feel
Fluoro.
AR will be less. I'm just pulling back, coming out. The catheter. Okay. So let's.
Low mag, so they can
Mag
see
out.
that covering now, you have to combine them, marry it, fluoro. Yeah. Good. So before we take it out. So
Okay, can you come to AP now?
Okay, Hemant, how does it look? If you
Any
have to do a
AR?
balloon, what size balloon will use? 22, huh? Nice. Okay, let's see. No, but if we have to use the balloon, what will be floor?
So we are going to use a balloon of 22
If needed.
if needed.
Good. Let's do it.
Okay, can you go to Cordal? Mag up. धीरे धीरे. Mag up. Okay. This looks perfect. I think no parallax at all. Okay.
Okay.
Ready?
Let's do the aortogram first.
Let's inject. Nice position, no AR at all over here. You can see that. So 16 French sheaths, please give us.
Okay. We come out. Yeah.
So the
16 French
sheath
sheath and
is
we
not
dilate
ready.
with the
The 22 French.
22 millimeter balloon.
Okay.
Now see, there is a gradient on the echo. It looks constrained. Yeah, yeah. So good. So we are going to put a sheath back. So Keith, you have to come out with a single detector. Less than 5 paravalvular peak. And second, less than 10 millimeter gradient. If not, you have to
Okay.
optimize it.
So we are putting back the.
Or no, paravalvular. That's good. Yep.
Okay. So now I'm taking out the dilator. Give us the balloon. 22 or no, 23 is too large for this. Less. 21 is there.
No, 22.
So 22 it doesn't come, sir. Or you can give us the Edward 22. 22 आता नहीं है sir.
No, have I brought 22 balloon? Huh? So what do you have 22? What do you have there? What is there? The plot.
AR is 0. Because we'll have to put the pigtail again, put back the wire.
That thing 50. What balloons we have at present?
We have a 20, 23.
23. Give us 23. ZMAT 22 नहीं है
22 आता नहीं है sir.
नहीं है लेके आया हूँ भाई
अच्छा यहाँ पे
कितने
नहीं।
लाया हूँ मैं आई हैव ब्रॉट 22 but in the past I didn't bring now but in the past we have brought 22 but that will be used but anyway let's use this
Okay, open this 23.
okay.
Yeah.
Mean was 21 right 21.7 see the Oxford 22 Oxford 22
Yeah, you got it? Okay. Yeah. Yeah, open that. Okay, prepare this balloon, please.
the 22 is better so after 18 there is 20 then 21 22 23 24 25 26 27 28 never used 30 anyway 28 is the maximum I ever used
Okay.
most important paravalvular leak or gradient If none of them looks, the sizing you want to just go to the mean. Your mean, not minimum, mean. The mean was 21.7, so 22 is good. And pre-dilatation you want to do lower than your smallest.
Don't push the balloon, please. Okay, just show us. Okay, sir. AP. Oh, you can stay in this. You can stay in this. No problem. It's a oval, so it's a oval, so थोड़ा सा अब जाइए सर, पीछे लेके सर, पीछे और पीछे लेके, हाँ. Okay. I think this is good enough, sir. Okay. So you can see sir is holding the balloon in a perfect way. One hand over there straight, and the second one over here, wire holding the rest of the fingers holding the wire. Let's space at 180, please. Okay, going up with the balloon. That was in senior, sir. Pacing off, please.
Now pacing off. Good. You see that constraints. Remember that gone. Good. Let's get the pigtail now. Oh,
That is come out. It's okay.
Let's get
We go by the gradient.
yeah. If we have
okay.
the gradient, we don't need to cross.
Yeah.
Yeah. Okay, Hemant, tell us where we are.
Good. So, okay. Can you come slightly caudal? Perfect. 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 Don't go further. Okay. Ready for injection? Inject. You can see there is no leak at all. This is the advantage of Pro in a severely calcified valve. What do you feel, sir?
Yeah.
Wait.
Lower now will be Pro Plus.
FX is way behind,
Keep
sir,
it.
for India. So can we put this dilator and close it now?
No. Pro Plus is like a Pro.
Okay. Prem, you can come this side.
Yeah. So native one, no. I mean, again, we know that has created a valve when you have biprosthetic valve or so, but native is usually not
Okay.
the problem.
Ready?
So MAC does not affect.
Okay.
It's not that the leaflet impinges into the outflow tract and cause the obstruction.
So we always look at MR after we deploy the before deploying the valve completely. If MR has increased, means either the coronary is getting closed or the AML is getting impinged. You can always retrieve and you can. Some of the cases, if the right coronary or the circ is getting placed, you can get MR because of that also. Because
Yeah,
of the
if
fact that-
valve is deep. If valve is deep, then it can prevent the motion, can impinge on, but not otherwise.
So we
This one
have.
also, I think we have to leave a pacemaker. Right?
We'll have to leave the pacemaker, sir, in this case. Okay, now I'm going to press. Yeah, put the bucket. So from the other side, we are going to put back the Lima catheter. Okay, where? Where? Okay, some contrast. We'll have to slowly leave that frame completely when I say. Okay, leave everything, Prem.
Good.
Good flow. Looks good to us. Okay. So now you can tie up both the things.
Bring that table
Bahar.
down.
I'll come there. You can knot it up. And we'll put a 8 French angiosyl as before. In
Yeah.
ये
Is
निकाल
that-
के दोनों को पुश करो. Okay. Pull back slightly and cut. Yeah. Angiosyl, please.
Groin.
So now Prem is going to push in the collagen. Lock it up. You get the click sound.
You
Pull
let me
back.
know.
We'll push this.
But otherly,
thing.
after this lady, then yeah, the next one with the balloon pump and all that complexity.
You can show that also if you want.
Yeah.
We can- I was actually about to tell you, sir. So we have another case which is Rota IABP guided Rota Pros, which sir will be doing. So if anyone is interested, can log on the same link.
Yeah, and they can go and see. There is another patient which is on the table right now. It's a very complex angulated circ coming from the, they put a stent across, left main to LED, and there's 95%. They want to send her for surgery, they tried. That's what we are going to do now. And then after that, this balloon pump case. Ostial circ, yeah. Yep. Trouble in anything, Achilles heel of international cardiology, no
Okay.
matter what you do.
And now
Circumflex off.
Now we are going to take an injection again.
Okay,
That's
now we have
already
to
in place,
transfer
some
this
contrast.
pacemaker to the neck. Right? Oh, pacemaker, actually rhythm has come back.
Rhythm has come back, sir. Actually, the depth is very good, sir, in this case.
Yeah.
So I think you may not need a pacemaker at all.
Let's say we turn off the pacemaker completely, see what happens. Yeah.
So on rhythm, sir. Okay. So us.
अब narrow की ओर आ गया.
Groin. Yeah, perfect. Sine. This is
This is
good.
good.
So
This
we
is
don't
acceptable.
need to-
Little bit narrowing is okay. That gets better. But compared to other one,
So we don't need to do anything. We'll close the other side also with an angiosyl.
Yep.
Sir, if we can, injection first, contrast. No, not
only
okay.
thing is we leave the sheath in case so that if acutely something happened, rapidly you can float the pacemaker. We leave the sheath in if there was there in the neck. That's the only thing.
So
which is different.
Seju, the other femoral. Slight LAO. Yeah. कर लो कोई बात नहीं. Okay. Okay, that's fine.
But what are the beats? Pacemaker is off.
It's way down.
It's a manual.
Manual. The bifurcation was very high in this case.
Yeah. Okay.
So, okay.
You go the.
So we completed this case. We saw that this case had a heavy calcification on the annulus, extending into the LVOT, right, both on the side of the NCC as well as on the side of the LCC. We
Previous
did
picture.
post
Previous.
pre-dilatation with a 18 mm balloon, deployed the valve. There was no leak
Previous.
because this is a Evolut Pro.
Previous.
And there was small amount of gradient, so we had to post dilate with a 22 mm balloon. Finally, we ended with a very good case. No leak, no gradient in a single digit. So I would like to request Dr.
Very good.
Tamasan to say something.
No, no, it's actually right position. This is what you're looking for, the 2 to 4 millimeter depth. And that decrease the chance of subsequent pacemaker and also decrease the paravalvular leak. The both things have happened appropriately. Go minus. And if you see, once we do the valve only, minus, minus. See that little constraint at in the middle, just above that calcium. Go next. With the balloon dilatation, you see, you opening here, next. Yeah, see, that disappeared. So that waste become little fat. But anyway, the purpose there was to optimize the hemodynamics. So no longer is the case of hurry and just do it that you have done the tower. No. Now we are to the next level that you have to basically do your all the hemodynamics and appropriately adjust, whether requiring an extra balloon or bigger valve or so and so forth, whatever need to be done, then come up with the hemodynamics. So adequate hemodynamics, because those are the ones going to give a long-term results. So there are actually one study going on, complete tower. That is same, like complete group of people who did for the STEMI. That do you do a PCI with the tower or just do the tower only, patient with the CAD? So goal there is you put that's done by the SAPIEN, but it's done by the organization, but their SAPIEN valve done, you've done a good hemodynamics, and then if randomized to either PCI or no PCI. Because data is that maybe it's the AS which caused the problem, not the CAD. So that is ongoing. So we are part of it. There actually they require that patient will come back every year for hemodynamic assessment. And once you start getting the gradient beyond 20, then you dilate the valve. So remember in the surgical, you just wait for the degeneration to occur. But in the prosthetic, particularly tower valve, you can change the hemodynamics when it starts deteriorating early. So let's expand it. And that's where the protocol, because the trial just started last year, so it's still very early, but they have the plan that every year hemodynamics, assessment of the valve and optimize the valve. So this is the first time nobody has done ever, the optimization of the tower valve once you start getting a 20 millimeter more gradient. So they just do keep advance. Hopefully that will prolong the life of the tower valve. So so no, they want a tower first, the tower non-complicated, then do the PCI, the same time or within 30 days. But tower first. But the SAPIEN valve, hopefully not. So those, they have the whole same thing. That has to be more than 10 millimeters, and so cases where access is not the issue. So those cases will be randomized, are being randomized. I mean, not, that's what's happening. So their access is not a problem because the SAPIEN valve, coronary access, as long as it was not a low height, less than 10 millimeters, is never a problem with that. Yeah. No, there is no data for the self. And even with the balloon, they actually incorporated in the trial. Nothing has been done yet, because I'm sure with the gradient 20 will start getting 3 or 4 years later, which is not yet. The mean gradient, yeah, 20. Yeah, that is how we start calling the remember, definition of the valve degeneration is more than 20 millimeter gradient. So that's the key is that 20 millimeter, don't let it go to 40, 50. Let's keep open, dilating. Surgical valve, you have trouble, but with our prosthetic valve, why not? And I'm sure same thing can apply for the evoluta also, but that's not the part of the trial. Trial is only for the SAPIEN at present.
Okay, thank you so
All
much
right,
for joining us. Thank you everybody for being in the lab, and thank you whole team. We'll see you next time, probably next month. We can have one more transmission. Thank you. TPI